Thank you everyone. So we are going to start our next session, and I request our expert panel, Dr. Bhalla sir and Sagarika Patel ma'am, to take the chair and start the session. As you all know, the presentation time is, Dr. Sahiba is also there. Please come for the. So this is basically a postgraduate case presentation session for judges. These are all PGs, and you can add, delete, suggest them, any improvement that can further do in their management of the such cases. And no, we have only expert panel and moderator. The expert panel will decide the number 1 to 3. So you three are only going to give me the number 1 to 3 list.
Also, judging is also there.
Yeah. So Dr. Snehita, are you here? Yeah, please come to that podium. And Dr. Arya, this will be followed by Dr. Arya. Yeah, you please ready for here, right?
Snehita.
So, welcome all delegates. It's wonderful to see such young faces. And you know, it's always the cobbly wobbles are there in the stomach when you're going to present for the first time. But just remember, we've all gone through the same phase. So it doesn't matter. What matters is that you've come here, taken the courage to present. So that's what we are going to admire, right? And remember, we are all learners. I'm going to learn from your cases, right? How best to improve myself. So we'll stick to time. That's very important. And so I'll request the first person, Snehita. Have I got the name right, beta? Yes. Okay. And your topic is DOAG. And don't give your this thing that I am so and so from this. No, you just begin. So you don't waste your time. Go ahead.
Good afternoon, everyone. I'm going to present a case of juvenile open-angle glaucoma. This is moving. It's a subset of glaucoma between 3 and 40 years of age with autosomal dominant inheritance, a male preponderance, and 87% of patients are myopic. 3.3% of newly diagnosed glaucoma in India is JOAG. The most common involved protein is myocillin protein, and it's less responsive to medications and often requires surgical therapy. A 45-year-old male came with diminution of vision in right eye since 1 month, which was gradual onset, painless, progressive in nature. He consulted elsewhere 10 years back and he was started on topical medications. He was on latanoprost and timolol in both the eyes and Dorzox in left eye. He had a very strong family history with his mother and his maternal uncle having the same complaints. So BCVA was done and both his eyes were improving to 6 parts with minus 4.25 diopter spherical and minus 3.50 diopter spherical in right and left eye respectively. On slit lamp examination, right eye, the lids had prolonged eyelashes and then the conjunctiva had mild congestion, the cornea was clear, the pupil was 3 mm, D plus brisk and C plus was sluggish, and the rest A's was within normal limits. ACVH grading was 3 and there was no cells present. Left eye had similar findings with just the pupil having grade 2 RAPD. On Goldman applanation tonometer done at 10 AM with all these topical medications, on right eye he had a pressure of 12 mmHg and left eye he had a pressure of 28 mmHg. The central corneal thickness was also done where right eye had 471 micrometers and left eye was 477 micrometers. Gonioscopy using 1 GM was done and all the 4 angles were having 3 of modified Schaffer's grading and there was no evidence of peripheral anti-synic present. Prominent iris processes were noted in both the eyes. On fundus examination, both eye media was clear. Right eye disc was 1.69 in size using correction factor and then the cup size was 0.6. The inferior thinning was noted and supratemporal and infratemporal RNFL defects were noted. In the left eye, the disc was 0.9 in cupping and then concentric NRR thinning was present. A gross RNFL defect was there. Bayonating of vessels and nasalization of vessels was also there. So OCT RNFL was done. In OCT RNFL map, the wedge defects could be picked up in right eye and left eye, and the inferior thinning in the right eye and all four quadrant thinning in the left eye was noted. C fields 24-2 was done, and right eye was appearing within normal limits, and the left eye had advanced glaucomatous changes. So we proceeded with the 10-2 C fields, and in 10-2 there was altitudinal defect as well as some generalized focal depressions in inferior fields. So diagnosis of both eye juvenile open angle glaucoma was done, and both eye selective laser trabeculoplasty was done, followed by which left eye trabeculectomy was done with mitomycin C as adjuvant under LA. Post trabeculectomy, the IOP in the left eye was 8 mm Hg. So what is unique in my case? It's a very uncommon yet a serious condition affecting the younger individuals. SLT is a promising first-line treatment option, and trabeculectomy in young patients has to be performed very meticulously. So it is very significant because it has a rapid progression and can lead to early vision loss. It has a strong genetic link and challenging to treat and monitor effectively. So the take-home message is that vigilant management is required to prevent the progression. A holistic and a multidisciplinary approach is very crucial to improve the quality of life and long-term visual outcomes, as these can have psychological and social impacts on all the individuals. Thank you.
Very good presentation. Dr. Bhalla, would you like to?
Yeah, just one point. Why did you do trabeculoplasty before undertaking? The left eye was already 28, and after trabeculoplasty it just dropped by 2 millimeters, and ultimately you had to do trabeculectomy.
Yes.
So why this intervening procedure?
So actually at the first visit the patient was not sure whether he wanted to be taken up for surgery when we asked we have to do trabeculectomy. So at that time because of few literature studies which suggest that SLT can also be used as an adjuvant in the case of trabeculectomy, we did SLT in the first visit when he came, and in the subsequent visit when he came we planned for trabeculectomy when he was actually ready for the surgery.
Do you think that you missed out on any history taking?
Yes, ma'am. All the negative histories were taken. I asked about steroid intake in form of inhalers or any topical medications, and also history of trauma to rule out any traumatic glaucoma. And we also, on anti-segment examination and as well as in gonioscopy, we can rule out this pigmentary glaucoma, pseudo-exfoliation glaucoma as well. Apart from that, other...
RNFL OCT for the right eye is normal.
Yes, ma'am. The right eye, that defect alone was noted, ma'am. The RNFL wedge defect. Yes, ma'am.
What were baseline IOPs?
The baseline IOP was 1 second. Oh, it's over. It was high, and both the left eye it was more high, ma'am. Right eye it was controlled because of the medications, and left eye, though on 3 topical medications, it was not controlled. It's around about 28.
Just one last question, I think. You've done very well, by the way. And I just wanted to ask you that, you've done OCT.
Yes, ma'am.
But did you check the signal strength of that? And why was the signal strength only 4 or 5? Okay, doesn't matter. It's okay. Thank you. Thank you very much.
Thank you, ma'am.
Can you please play it from the start?
So next person, I'm calling out for the next person, yes. So we have our young SS Arya.
Yes.
Yeah, and she's going to talk about bilateral malignant glaucoma. It's a wonderful topic, and I'm sure we're going to do justice to it. Go ahead.
Thank you.
Don't waste your time.
Good morning, one and all. So I'll directly move on to my case. My patient was a 69-year-old male who was a farmer by occupation who presented to the acute emergency with complaints of sudden onset profound loss of vision in both the eyes for past 4 days. It was associated with redness, watering, photophobia and headache. There was no history of similar episodes in the past, no history of any trauma, use of any ocular medications or any other ocular surgeries. On examination, his distant visual acuity in right eye was hand movement close to face, and in left eye was finger counting at 2 meters. The extraocular movements were normal. Anterior segment examination showed lid edema in both right and left eye circumcorneal congestion in both the eyes. Cornea showed epithelial and stromal edema. The pupil were mid-dilated ovally, sluggishly reacting to light. Iris showed atrophic patches. There was no NBI. AC was shallow throughout and with Van Herrick's grade 1 depth, and lens showed grade 2 nuclear sclerosis. The fundus was hazy due to media opacity. By Goldman applanation tonometry, the IOP in the right eye was 32 mmHg and in left eye was 28 mmHg, and the CCT was also recorded. These are the anterior segment photos where we can see the corneal haze with the ovally dilated pupil in both the eyes, and the conical section photo where we can see the shallow anterior chamber. So in view of the above findings, we came to a working diagnosis of acute angle closure of both eyes, and he was started on IV 20% mannitol that was given 12 hours apart, and simultaneously he was also started on hydropilocarpine, oral acetazolamide along with other topical anti-glaucoma medications. However, to our surprise, the patient did not improve, and not only that, his symptoms had worsened. So we went on to further investigations, and on ultrasound biomicroscopy scan, we found significant ciliary body swelling, and we went on to do a USG-B scan where we saw exudative RD. We went on to ask few more questions to the patient, where he came up with history of seizure episodes, last episode happening 1 month back, and he was started on tablet carbamazepine by a local clinician. Thus, we came to a revised diagnosis of malignant glaucoma both eyes. Hydropilocarpine was stopped immediately, and he was started on atropine along with timolol, oral acetazolamide, oral and topical steroids. He was evaluated by the medical specialist and was diagnosed as seizure disorder. Then post-treatment, we could see the anterior subcapsular opacities, clear cornea, well-formed AC, and the iris atrophic patches. The IL Master 700 was done that showed normal axial length parameters in both the eyes. The posterior segment photo shows a resolved exudative RD, and a post-repeat UBM scan shows significant reduction in the ciliary body swelling and a wide open angle. Thus, I would like to say that such a case of spontaneous and bilateral malignant glaucoma is rare. And why my case is malignant glaucoma? Because on examination we saw that there was shallow AC throughout, and the patient had worsened with miotic treatment and improved with atropine. And on UBM we also saw significant ciliary body swelling that was a secondary cause. So the take-home message would be that in case of shallow AC, we have to think of other secondary causes, and yes, going back to history made all the difference. Thank you.
Could you explain what is the cause of the anterior subcapsular opacities and patches of iris atrophy also?
Yes, sir, probably we believe that the patient might have had previous attacks of acute angle closure but was not noticed by the patient. There might have been a pre-existing acute angle closure.
Patient had the previous subacute attacks of angle closure initially, and you think that following initiation of carbamazepine for his seizures,
yes, sir,
the patient developed malignant glaucoma.
Yes, sir.
Is it documented in the literature?
So there have been cases reported where there have been angle closure with raised IOPs with carbamazepine and gabapentin, sir.
Angle closure?
Angle closures.
But not malignant glaucoma?
No, sir.
So how did you arrive at the diagnosis of malignant glaucoma in this patient? Just because of worsening with pilocarpine?
No, sir. Also, the UBM scan that showed a significant ciliary body swelling that was seen in the UBM scan, sir, that made us come to a diagnosis.
Any rotation of ciliary processes?
Yes, sir. That was noted. That was noted in the UBM scans.
What is the axial length of the eye, and do you think that matters?
Yes, ma'am, because that also again is a predisposing factor that can lead to anatomical predisposing factor that can cause malignant glaucoma. In this patient, it was normal, ma'am. It was 22.03 and 22.3 in the left eye, right and left eye.
So then in that case, how would you clinically differentiate? Because what I understand is like over here, the diagnosis of malignant glaucoma is a little gray area. How would you clinically differentiate, let's say not this case, a typical case of malignant glaucoma
uh, acute angle closure, ma'am, of course, the patient usually improves with normal conventional.
Would you like to do some intervention in order to then check back?
Yes,
With
ma'am.
what intervention?
A
would you
YAG
like to
PI would be should be done, and we can see whether the patient improves with it or not, which usually improves with acute angle closure, whereas the patient usually does not improve with malignant glaucoma.
Any difference in central anterior chamber depth and the peripheral?
Yes, sir. Yes, sir. In case of acute angle closure, the AC is shallow peripherally, whereas it is deep centrally. In case of malignant glaucoma, it's noted that it is shallow throughout.
And any investigative procedure where you can really find out besides UBM?
ASOCT, sir, and known as a non-invasive procedure. Initially, ASOCT can be done. In our patient, we couldn't do it because of the corneal haze initially, corneal edema.
Fine. It's a very good case. Thank you. We'll call the next person, please. So the next doctor is Dr. R.C. Deepak, bilateral angle closure. So we have another one, angle closure. Great. So don't waste your time by saying so and so and so. Just go straight for the topic.
Good afternoon to you all. Case is rare case of bilateral spontaneous angle closure glaucoma. Case details: 42-year female lover presented with acute bilateral diminution of vision, pain, redness, and swelling in both eyes. Symptoms were accompanied by severe headache, progressive visual impairment, and elevated IOP. Patient had prior history of unilateral headache and was a known case of hypothyroidism. On 23/11/2024, she presented to us with right eye vision of 6/24 and left eye 6/12, with a pressure of 16 right eye and left eye 31. Cornea right eye was hazy, left eye was clear. Pupil was normal. DT was stony hard in both eye and was managed with tab acetazolamide, TDS, dorsalamide 8-hourly, timolol BD. Next day, the vision of right eye was 6/12 and left eye was 6/36, and pressure was both eye was non-recordable. Both eye conjunctiva was congested and chemosed. Cornea was hazy, AC shallow, VH grade 0, cells occasional, pupil was mid-dilated and fixed, DT was stony hard, color vision was normal and contrast was right eye 5% and left eye 25%. Hertz were 20 and 19 respectively. Injection mannitol 300 ml infusion in 1 hour was given. Eye drop bromidine plus timolol, TDS, pilocarpine QID, CMC 1 hourly, prednisolone 8 times, syrup glycerol 380 ml, TDS was given. Next day, the vision got improved to 6/6 in both eye. NCT of right eye 15 and left eye 16. CCT was within normal limits. All other findings were within normal limits with AC depth of VH grade 1. Eye drop moxifloxacin plus lotipratinol 6 times, brimodine timolol QID, refresh TS 6 times, tab Dimox was given. This was the picture of the presentation, and this was 2 days after. This was the slit lamp examination showing VS grade 1 and fundus picture showing optic disc blurring and hyperemia of disc. This is the ASOCT showing right eye showing angle 14 and 8 in right eye and AC depth of 1.10 millimeter. Left eye it was 12 in both sides and AC depth of 1.123. 2 days after, ASOCT angle got improved to 20/23 in right eye and AC depth of 1.5 millimeter. In left eye it was 22 and 19 with AC depth of 1.452 millimeter. What's unique? The case is unique due to the simultaneous bilateral presentation of angle closure glaucoma, which is relatively uncommon. Additionally, the presence of hypothyroidism raised the possibility of underlying systemic influences contributing to the patient's condition. Response to the treatment as followed, as documented in the follow-up visit, highlights the dynamic nature of glaucoma management and importance of personalized treatment strategies. The case underscores the need for comprehensive ocular and systemic evaluation in patients presenting with sudden visual disturbance and pain. Early recognition and aggressive medical therapy can prevent irreversible optic nerve damage. The association with hypothyroidism also calls for the interdisciplinary approach in managing such cases. Simultaneous bilateral angle closure glaucoma is rare but sight-threatening condition due to requiring immediate intervention. High index of suspicion, timely referral, and appropriate medical management are crucial. The case highlights the importance of recognizing systemic association and the role of thorough follow-up in ensuring optimum patient outcomes. Thank you.
So, good case, Dr. Deepak. Mics are not working. Can you hear me?
Yes.
Okay. So, first of all, I felt that your examination results were a little skewed. You'd made up your mind that this is the diagnosis, and then retrospectively, you're writing the examination details. So make it very, very fair. Just if you're presenting this case in front of an examiner, that really matters. So don't use strong words like stony hard. You know, one eye vision was gone, next day brilliant vision. So let's not do that. Give facts, okay, and then slowly gradually come to a diagnosis logically, step by step. Okay, so also what we did not understand, how ma'am was also pointing out, how color vision was taken. How was that possible with a hazy cornea, with a 636 vision, stony hard eye? Patients generally don't cooperate. Even if they do, you even said the fundus is hazy, so it's very difficult for color vision to come out as 21 by 21.
Fundus was not hazy. The optic disc was blurred, and there was slight hyperemia. Fundus was clear.
Right, but you think these
I would, doctor, agree with that it is, it's very difficult really for us to understand how a person with 60 pressures, you know, you'll be having so much of corneal edema that you are being able to see the fundus. Or for that matter, you are being able to even check the vision. Or for that matter, you're being able to do the color vision or the contrast. In fact, it would not have even occurred to me to do the color vision, to tell the truth. Yeah. No other
Yeah, I
question,
agree.
then it's okay.
It becomes difficult, practically speaking, with the steamy cornea at 60 millimeter of mercury pressure, where it is difficult to go see beyond the cornea. You cannot expect patient to be able to really see, do the color vision testing. I think it is unthinkable. Anyway, so this is just a advice what we are giving you. So color vision is not possible. You could have said color vision was tried, testing was tried, but it was, results were equivocal or something like that. Okay.
So color vision was not done on the first day when the pressure is, it is done on the second day, when the pressure became normal.
In 1 day's time, the pressure reduced.
From 62, it came down to
60 to 15. But second day 50. First day
Within
it was
1 day.
60. No, first day it was 60.
60. Second day it was
Yes,
15.
No, not recordable. Then third day it was 15.
was any laser done? Was a laser
No, sir.
or PI done?
No.
So how do you expect an angle closure to settle without you opening up the angle just by medical management? What was the cause of angle closure? Was there a secondary cause and not a primary angle closure?
In MRI was done, ma'am, and it shows mild inflammation of the extraocular muscles.
Okay.
So
How is that
how
correlating
does
with
that, do you think,
intraocular findings?
how do you hypothesize that swelling of the extraocular muscle will lead to,
Swelling
it is
of
not
the,
that means it's non-pupillary block mechanism?
it may, the swelling of the extraocular muscles and preseptal tissue may lead to angle closure.
And also, why should you even think of an MRI in a case of bilateral angle closure? I'm sorry, I'm not being able to understand. Anyway, it's okay. It's okay.
Right.
See, I said, courage to come along and present. Great. Thank you. Thank you so much.
Thank you.
Now we'll invite Dr. Spurti Tripathi.
If you all know the sequence, be ready at the next stop
Yeah.
so that we don't have to call and waste time.
Next speaker, Arun Sahi, please, please come in the front row. Other speakers also be ready. Arun, is your presentation ready?
Yeah, just go
Yeah,
ahead.
please.
Then go ahead. Don't worry. Arun, you come along. You present. Then she can present later.
Yeah. Vesak to be ready after Spurti. Vesak is there? Yeah, please come.
Hello.
Please put his PPT on, please. Please put Dr. Arun's PPT on.
Thank you.
Yeah.
So
all.
that's it.
Yeah, it's
Here
come
it's-
to us.
Here
Just
it's
press OK and start.
Okay, beta. You ready? No, beta. No problem.
It's not coming here. It must be there only.
Okay, go ahead.
Yes. Good afternoon, everyone. Today I'll be presenting a case on refractory secondary glaucoma following pterygium excision with autograft. So my patient is a 54-year-old female from Kadalur, presented with chief complaints of pain, redness in left eye for the last 14 days. It was insidious in onset, constant, dull aching in nature, without any aggravating and relieving factors for the last 2 weeks. There was no radiation of pain. It is associated with diminution of vision and intolerance to ambient light. There were no history of colored halos. Patient gives this following brief medical history. In June 1st week, patient underwent left eye pterygium excision with conjunctival limbal autograft. 40 days later, she developed eye pain and diminution of vision along with photophobia. At that time, the patient's vision was 360 and cells were anterior chamber cells were 2 plus with mild corneal edema. IOP was measured as 44 millimeter of mercury and not controlled on maximum medical therapy and referred to her college. At the time, she was on three topical AGMs, one topical prednisolone drop, oral lestosolimide, and IV mannitol. Still, the IOP was remained high. Patient has no systemic comorbidities. On examination, general and systemic examination was within normal limits. Coming to left eye examination, vision was 560 with marked conjunctival congestion with localized corneal haze with vascularization nasally at the area of pterygium excision, and the anterior chamber depth was Van Herrick's grading 2 with cells 2 plus, and the pupil was 4 mm fixed dilated. There were pigments on the anterior lens capsule with broken synechiae, and IOP was 34 millimeter of mercury by GAT. These are the gonioscopy images. The right eye showed open angles and the left eye had slightly narrower angles. Coming to fundus examination, the right eye fundus was within normal limits. Left eye media was hazy due to cataract and the disc color was normal, but cup disc ratio was around 0.7 with concentric NRR thinning. And rest, there were no evidence of RNFL defects or no evidence of disc hemorrhages. With the central corneal thickness of the right eye was 640 microns and left eye was 610. OCT, RNFL, C fields were not reliable as the signal strength was poor. So with no further delay, we started the patient. We stopped topical prednisolone in view of steroid responder, and we have given topical AGMs and intravenous mannitol to lower the intraocular pressure. To reduce the ongoing inflammation, we have started on fluorometholone eye drops. 48 hours later, intraocular pressure was 36 millimeter of mercury. There was transient drop in IOP noted post mannitol, but the IOP remained elevated otherwise. The anterior chamber became quiet. So we have proceeded with trabeculectomy with mitomycin C augmentation. So these are the post-op images. By end of 3rd week, patient cornea became clear and the pressure was maintained at 12. So unique features were, this is the uncommon post-pterygium surgery complication. There were multiple potential causes of IOP elevation. There is mixed mechanisms. And there is resistance to maximum medical therapy. And successful surgical outcome was seen in this case. So clinical implication, so elevated IOP post-pterygium excision, it can be due to steroid-induced or pre-existing glaucoma, uveitic glaucoma, altered downstream drainage of aqueous due to the pterygium surgery per se, or altered corneal biomechanics. So my take-home message is, you should recognize the multifactorial causes of glaucoma, and you should use steroids judiciously in post-operative management. Early surgical management is important in refractory cases like this, and personal treatment approach to different cases. Thank you.
I just want to ask you, doctor, first of all, it's a very nice case that you've shown us, but I just wanted to ask you that don't you think that the optic disc in the concerned eye, it was definitely showing evidence of glaucomatous damage from the very beginning. It couldn't have been that in 1 month's time, the optic disc could have shown these kind of changes. So what do you feel this is? Would you like to revise your statement, your diagnosis?
Maybe for the last 40 days since the pressures were high, maybe this in 40 days there could have been chance of the optic nerve being damaged because of high IOP, because it was at in range of 30s to 40s even on medical therapy.
So you feel that the optic nerve could have shown such rapid change in the CDR ratio that inferior neuroretinal rim almost is thinning, or would you like to prefer to say that yes, the patient was a case of glaucoma, was therefore more prone to being a steroid responder, and therefore the moment the steroids were given, he showed a steroid response, which could have also been seen in the other eye, fellow eye, which was not seen,
there.
and therefore this patient landed up with this. Would you like to say that, or would you like to stick to your diagnosis? Entirely up to you.
Actually, we didn't come to the proper diagnosis, ma'am, because after stopping the steroids also the IOP was not controlled. Even
Takes
after
time. It takes time.
Even after controlling inflammation, so maybe due to the effect of steroids, there is chronic damage to the tubercular meshwork. So even after stopping the steroids, the IOP is not controlled. So it might need trabeculectomy for that.
Do you want to explore the idea of it being completely unrelated to the pterygium surgery?
It might be the cause.
In that case, what will be the diagnosis? The cause of glaucoma? You explained so many clinical features, right? There was pigmentation on the endothelium.
Yeah, it can be uveitic glaucoma.
Correct.
Or,
so steroid-induced glaucoma doesn't present a clinical picture like this. So that's completely out. It is not a steroid-induced glaucoma, and also it takes, how long does a steroid take to cause an IOP spike?
More than 6 weeks.
More than 6 weeks? So no, it can in a couple of weeks also, but in the time difference between your pterygium surgery and the development of very high IOPs was only 40 days.
Yes, ma'am.
Right? So that itself doesn't really fit in that very well, and also for it to cause so much of RNFL damage also within those few couple of weeks is also a little not understandable. Yeah, so it looks more like an unrelated uveitic glaucoma to me as well, on the basis of the clinical features. It's very straightforward.
But thank you. It's a good thing for us to think about. Thank you very much.
Thank you.
The next lady, please come.
Sfurti is ready? Come. So Sfurti is going to be presenting a case on plateau virus.
Good morning. Today's topic is when the plateau steepens, a case of plateau iris syndrome with key takeaways.
Doesn't matter. It's okay.
When the plateau steepens, a case of plateau iris syndrome with key takeaways. Okay, plateau iris configuration includes narrow angles and a flat iris plane. Also includes an anterior rotation of ciliary process which may lead to the angle closure. On gonioscopy, we can also see double hump or sigma sign. So, a 30-year female presented with chief complaint of sudden painful progressive diminution of vision associated with headache and redness in both eyes since 3 days. She was a known case of glaucoma on 4 anti-glaucoma medications, had a past history of spectacle use, had a history of both eye laser PI done 3 months back. On ocular examination, her distant vision was 660, improving to 636 with pinhole, with plus 6 diopters sphere in the right eye and plus 4 diopter sphere in the left eye. On slit lamp examination, anterior chamber was shallow with VH grade 1. Both eyes patent PI marks were present, and both eyes had pinpoint pupil under the effect of pilocarpine. And on GAT, the pressure in both eyes was 24 mmHg. Also on fundus examination, we can see glaucomatous changes with deep cup and Okay. Pressure in both eyes was 24 mmHg. Central corneal thickness in right eye was 486 micron, in left eye was 455 microns. Corrected IOP in right eye 28 mmHg and in left eye was 30 mmHg. On gonioscopy, all angle was closed. We could see the double hump sign and 360-degree peripheral anterior synecdoche was present. On biometry, axial length in right eye was 16.95 mm, in left eye was 16.91 mm. Anterior chamber depth in right eye 2.05 mm, 2.09 mm in the left eye. Lens thickness 3.52 mm in the right eye and 3.18 mm in the left eye. Lens axial factor in the right eye was 0.20, in left eye was 0.18. Keratometry, K1 value in the right eye was 48.50 diopters, in left eye was 48.25 diopters. K2 was 50 diopters in the right eye, and in left eye it was 50.50 diopters. Anterior segment OCT was done, which was suggestive of plateau virus. Perimetry was done, which showed generalized reduction of the visual fields. So the diagnosis could be both eye primary angle closure glaucoma with nanophthalmos with plateau iris syndrome, and left eye trabeculectomy was planned for the patient. This is unique. As we all know, plateau iris syndrome is a bit uncommon, and its occurrence in the nanophthalmic eye is even rarer, making this case highly unusual. While primary angle closure in nanophthalmos is often due to pupillary block, this case highlights a non-pupillary block mechanism, emphasizing the importance of gonioscopy and anterior segment OCT. Clinically, it is important to suspect plateau iris syndrome if the peripheral anterior chamber is shallow despite a patent PI, or if there is a high plateau iris configuration on gonioscopy, or if there has been an angle closure glaucoma crisis despite a patent PI. It requires gonioscopy and anterior segment OCT for diagnosis. Differential diagnosis includes imperforate or occluded iridotomy with persistent pupillary block, multiple cysts of the iris or ciliary body, ciliary block glaucoma, open angle glaucoma with anatomically narrow angles. So the take home message is, it is a complex, sight threatening condition requiring early identification, long term monitoring and often surgical intervention to prevent irreversible vision loss. Thank you.
You said it requires just one question. You require gonioscopy and ASOCT to make diagnosis of plateau iris. Will you like to modify your statement? ASOCT, because the mechanism is the rotation of the ciliary processes, and with ASOCT you cannot go behind the iris and ciliary body.
Yes, sir.
So I think you need to modify that statement.
Sir, we can also, on gonioscopy, we can see the closed angles.
Gonioscopy is okay.
Yes, sir.
Gonioscopy is okay.
Ultrasound biomicroscopy can also be done.
But you did not mention.
Yes.
You mentioned ASOCT.
Yes,
so
sir.
I want to correct, because that should not be the message.
Yes, sir.
Which should go that you require ASOCT to make diagnosis of plateau iris. That is factually incorrect.
Yes, sir.
Okay.
So it is basically a clinical diagnosis, and nanophthalmos itself is a very complex this thing. So it's another ball game altogether. Thank you for the presentation.
Thank you, ma'am.
Next.
So my topic is atypical retinitis pigmentosa complicated by neovascular glaucoma.
Go ahead. Please go ahead.
Yeah.
Your slide is coming?
Yeah. So introduction. Retinitis pigmentosa is clinically and genetically heterogeneous group of inherited retinal disorders characterized by diffuse progressive dysfunction of predominantly rod photoreceptors with subsequent degeneration of cone photoreceptors and RPE. So retinitis pigmentosa related retinal detachment is rare, and the full spectrum of retinal complications is not well defined. Alstom syndrome is a rare autosomal recessive genetic disorder characterized by cone rod dystrophy, hearing loss, childhood truncal obesity, insulin resistance, type 2 diabetes, hypertriglyceridemia, short stature in adulthood, cardiomyopathy, progressive pulmonary, hepatic and renal dysfunction. So we are reporting a case of suspected Alstom syndrome with atypical retinitis pigmentosa complicated by retinal detachment and neovascular glaucoma. So it is a 17-year-old male patient presented with a diminution of vision, pain and redness in the right eye since 6 months with alleged history of trauma with fist to the same eye 6 months ago. Patient also gives history of hearing loss. PTA was history of bilateral moderate to severe sensory nodal hearing loss and reduced scholastic performance. There is history of second degree consanguineous marriage in parents. So the physical examination reveals short stature, gynecomastia, central obesity, abdominal striae, cafe LF spots and acanthus nigricans. So the ocular examination in the right eye, vision was already PL negative and color vision couldn't be assessed. Conjunctival circumcorneal congestion was there and cornea was clear. Iris florid NVA was there. BH 1 Herring's grade 2. Pupil was irregular and seclusion of pupilla was present with ectropion UVA and it was non-reactive. Goldman supination tonometry revealed 54 mm mercury IOP and gonioscopy it was G0 in all angles. The other eye was relatively normal and 624 vision and rest examination was within normal limits. This is the right eye showing the features, and it also developed complicated cataract and media was hazy due to cataract. The V scan revealed funnel RD. In the left eye, the cup disc ratio was normal, but bony spicules were present in the periphery. So as the intraocular pressure didn't come down with systemic as well as maximum topical anti-glaucoma medications, patient underwent right eye 180-degree cyclocryotherapy for absolute glaucoma and refractive correction was given to the left eye. So patient improved symptomatically in the right eye post cyclocryotherapy and was maintained on topical anti-glaucoma medications and cycloplegics. Visual acuity in the left eye improved to 6/9 with spectacle correction. So in this rare case of atypical retinitis pigmentosa complicated by total retinal detachment and neovascular glaucoma, timely management of intractable high IOP by cyclocryotherapy aided in alleviation of pain and thereby quality of life of the patient. He was advised dietary and lifestyle modification by endocrinologist for tackling obesity, insulin resistance and hypertriglyceridemia. Multidisciplinary care is of utmost importance in such syndromic cases for early identification and management of multisystemic manifestations.
What do you think has been the cause of the neovascular glaucoma? Only we'll take one question per person because otherwise we run short of time. to be faster?
Yeah, mostly due to like history of trauma with fist to the eye and uveitic glaucoma.
So what were the signs of uveitis? No, in this particular case, what is the cause? Ma'am is asking, in this particular case, what is the cause of neovascular glaucoma?
Diabetes is a like major cause, like this type 2.
You had diabetic retinopathy in the other eye also?
No, it is normal.
So that is not.
Yeah, it is
not. That is contradicting your this thing. That is what we are asking him then.
NVI will occur because of the inflammation, not because of the ischemia.
That's
so that the cause is totally different and it's staring at you in the face.
Will be because of closure of angle because of the past formation. Not
that is a secondary glaucoma, right? Not because
not a neovascular glaucoma.
Anyway, thank you. It's a rare case, difficult case to diagnose. We also learning from that. Thank you very much. We'll call the next speaker.
So next is Wrinkle Goyal.
Good afternoon all. By today's case is cyclodialysis repair, a ring of hope. A 43-year-old female presented to us with blunt trauma to her left eye due to firecracker injury. On presentation, her visual acuity in left eye was 1/60, intraocular pressure was 12 millimeters of mercury. There was a nasal conjunctival tear with multiple linear abrasions on the cornea. Anterior chamber depth was irregular with hyphema cells and flare. There was traumatic mydriasis. As the fundus could not be visualized, we did a B scan which showed choroidal effusion. The patient was managed conservatively with saline wash and further topical antibiotics, steroids, cycloplegics and tear substitutes. 1 month later, her visual acuity improved to 6/36, but IOP remained to be low at 3 millimeters of mercury. Anterior chamber depth was shallow. Fundus showed optic disc edema with internal limiting membrane folds. Patient was further advised on OCT, which showed hypotony maculopathy. So to rule out the cause of this hypotony, we decided to do an ultrasound biomicroscopy, which revealed a cyclodialysis cleft, which was further confirmed on anterior segment OCT in the superior nasal quadrant. So the diagnosis of cyclodialysis was confirmed. Patient was started on topical steroids and cycloplegics, but IOP remained to be low. After that, oral steroids were started in tapering doses, but there was no signs of improvement. As the hypotony was refractory to conservative management, we had to think of a surgical plan, but there were multiple options which surgery to do. Ultimately, we decided to proceed with cyclodialysis repair using Sione ring combined with phacoemulsification and a 3-piece intraocular lens. Surgery was uneventful. 2 months later, her best corrected visual acuity was 6/6. IOP improved to 15 millimeters of mercury. Anterior chamber depth was normal and fundus showed resolution of optic disc edema. Post-operative OCT showed resolution of the hypotony maculopathy and post-operative ASOCT showed closure of the cyclodialysis cleft. So moving to the discussion, what is cyclodialysis? It is the separation of the longitudinal fibers of the ciliary body from the scleral spur, which causes an abnormal connection between the anterior chamber and the suprachoroidal space, leading to increased aqueous outflow, thus hypotony. The most common cause of cyclodialysis is the trauma, and it can be caused iatrogenically as well. Management, we can manage it conservatively, or we can seal the cyclodialysis cleft with lasers, or it can be managed surgically by ab externo or ab interno procedures. Ab interno, we can do exocyclopexy, exocyclotamponade. Ab interno procedures can be endocyclopexy and endocyclotamponade. Why we need to timely diagnose and manage this cases, because untreated cyclodialysis can lead to serious complications like hypotony, edema, cataract, choroidal effusion, which can eventually lead to irreversible loss of vision. Why this case? Cyclodialysis is a rare occurrence and it being veiled behind the iris is difficult to diagnose and treat. We not only timely diagnosed the cleft but came up with an innovative, safe and minimally invasive surgery. How does this technique works is, it provides dual mechanism of action by providing endocyclotamponade and endocyclopexy. It is a minimally invasive technique with good safety profile, no need for scleral cut down. The take-home message for this presentation is that ab interno techniques can offer good success rates with better safety profile, and they can be considered as a viable alternative to standard exocyclic procedures. Thank you.
I think it was an excellent case and it was superb, and what you have presented to us and told us about a new technique which is very nice. Thank you very much.
Thank you.
May we have next speaker, please?
Wrinkle, what was the clock hour of cyclodialysis?
Cyclodialysis on 3 clock hours.
Yeah, so you have to also mention that these endodamponars, they work only for a limited.
Yes,
if it is more than that, you have to do external.
Thank you, ma'am.
Yeah, the next person, please. Doctors, please,
Dr.
please,
Hemlata is there.
please be at your
Dr. Prince
respective
Abu
place.
Amir. Yeah, you can come.
Please be at your, the next speaker, please be at the
Asha
lectern.
Modi and Sipra Burman may also come to the front row, please.
Yeah, please go ahead, doctor.
Asha, you are speaking?
Yes.
Okay, please.
Good afternoon. I am presenting a case on blebitis with an underlying bleb leak. Bleb-related infections are common post-filtration surgeries. The spectrum ranges from localized ocular inflammation in stage 1, which if not treated promptly can lead to anterior chamber involvement in stage 2, and in stage 3 there is involvement of vitreous, which is a sight threatening stage. The use of intra-op antimetabolites, which lead to thin-walled blebs, cystic blebs, are the most common risk factors. Limbus-based flaps are also a risk factor for blebitis. Young patients and myopic patients are at most risk. The clinical features are sudden onset pain, redness, photophobia. There is presence of conjunctival hyperemia. A white opaque bleb is seen. A typical white on red appearance is seen. Anterior chamber reaction may or may not be present. A 45-year-old male presented with complaint of redness and pain in right eye since 5 days, which is the only seeing eye. He had similar episodes in past, which he took treatment elsewhere. The patient underwent combined surgery for cataract and glaucoma a few years back. The visual acuity was 6.6 in right eye. The intraocular pressure was 12 millimeters of mercury. There was presence of purulent discharge, circumcorneal congestion, a localized white opaque thin-walled bleb with overlying cystic changes was noted. Seedles test was positive. Anterior segment and vitreous were clear. So we see that this is a case of stage 1 bleb-related infection, and the patient was started on topical antibiotics hourly, and oral analgesics were prescribed for symptomatic relief. The patient was explained the potential sight-threatening complication if not treated promptly, and was called for a follow-up on day 3. There was significant improvement in symptoms, so the same treatment was continued, and the patient was called. There was significant improvement in the inflammation on day 5, and the frequency of antibiotics was decreased on day 5 to 6 times. On day 10, there was complete resolution of blebitis, but there was but BCL application was done for the brisk bleb leak, and BCL application was done for the bleb leak, and the patient was started on oral doxycycline for 2 weeks. After 2 weeks, due to persistent bleb leak, the patient was taken for a surgical bleb repair, and the bleb repair was successfully carried out, and the diseased part was excised, and healthy conjunctiva was used to cover the scleral bed. The
if you have many more slides, then we'll stop it. If you have just one more slide, then continue.
Yes, ma'am. The challenging part in my case was addressing a one-eyed patient's deep-seated fear and counseling the patient about the sight-threatening complications, and balancing the urgency of treatment was necessary in this
Ma'am, I have
case.
just one question, and that is, why did you give doxycycline afterwards? Why was doxycycline not given before?
The patient underwent the combined surgery elsewhere few years back. So, because doxycycline has a wound healing.
That's why I'm asking you.
Why later on?
He used it as an antibiotic. That's what
Yes,
you're trying to say.
after BCL application.
Still, it's not the first line antibiotic that you
That's not
give
the
when.
antibiotic you would want to
Okay,
give.
so the rationale for doxycycline, if you want to give for epithelial healing, it's not for such big defects.
Anyway, thank you. Good case.
Thank you.
Yeah, next person, please. Dr. Prince.
Good afternoon, everyone. So, a 35-year-old South Asian male presented to the ophthalmology emergency with chief complaints of pain and diminution of vision in the left eye since 4 hours. There was no history of similar illness in the past, no history of any ocular trauma, surgery, redness, pain, congestion, no previous history. There's only one history, that patient is an occasional cigarette smoker since past 10 years. So on examination, the right eye examination was mostly within normal limits. The BCVA was 6/6. In the left eye, the vision was 3/60, which was not improving on pinhole. There was mild sluggish reaction of the pupil with mid-dilated pupil, and there was mild congestion of the conjunctiva, and grade 1 to 2 corneal edema was present. As you can see in this diagram, right eye is VH grade 4, left eye is VH grade 1 with grade 1 to 2 corneal edema. And on fundus examination, you can see in the right eye there is mild hypertensive retinopathy. In the left eye there is, in both the eyes there is severe hypertensive retinopathy, which is characterized by disc edema, arteriolar attenuation, AV cross changes. This feature doesn't have, this image doesn't have typical features of malignant hypertension such as macular star or hemorrhages or soft X-rays, but since there was disc edema, so we characterized it as severe hypertensive retinopathy. So, in the peripheral examination in the nasal periphery, there was this lesion which was query suprachoroidal hemorrhage. And after all these findings, we checked the BP of the patient, and it turned out to be 230 by 130 millimeters of mercury. Pulse rate was 89 per minute, and the rest general examination was within normal limits. So provisional diagnosis we made, both eyes severe hypertensive retinopathy according to Wong and Mitchell classification, with left eye acute angle closure crisis post query suprachoroidal hemorrhage with hypertensive emergency. Now since the BP was so raised, we started the patient on management right away. We referred him to medicine emergency for blood pressure control. Tablet acetazolamide and glycerol were started according to body weight after clearance from the Department of Medicine. We did not start mannitol because of high BP, and topical anti-glaucoma medications were also given. Patient was investigated for end organ failure associated with hypertensive emergency. So after BP stabilization, we did investigations on ultrasound B scan. You can see in the right eye there is normal retinochoroidal thickness. In the left eye, the retinochoroidal thickness is increased, and there is this raised localized anterior lesion with no after movements suggestive of suprachoroidal hemorrhage. We did UBM. In the right eye, you can see deep anterior chamber. In the left eye, you can see shallow anterior chamber and anteriorly pushed lens iris diaphragm. We did OCT RNFL, in which you can see increased RNFL thickness, and there is swelling of the optic nerve head. For systemic evaluation, creatinine of the patient is increased, which suggests kidney compromise. SGOT, SGPT are increased, which suggests liver compromise. And this is 2D ecography, echocardiography. Ejection fraction is decreased. There is mitral regurgitation. There is concentric LVH, which suggests cardiac compromise. MRI brain was done, and there was this periventricular infarct, which was picked up. But despite all these features, the patient did not have any systemic complaints. So the final diagnosis is both eyes severe hypertensive retinopathy with left eye acute angle closure crisis with now confirmed suprachoroidal hemorrhage with hypertensive emergency and confirmed end organ damage. There was loss of follow-up because the patient kind of got scared for his life. So on follow-up, there is this brownish lesion which suggests previous suprachoroidal hemorrhage. The disc edema has resolved and there are no glaucomatous changes. The IOP is 14 mm of mercury on no anti-glaucoma. There was a similar case reported in 2010 in Iran, in which the features were similar, but there was no end organ damage. And in 2018 also, there was a similar case presented.
You have, I think, already crossed the time. You must stick to the time because marks are cut for overshooting the time, okay? Can you just summarize?
Yes, sir. So the take-home message is that hypertensive patients can present with just ophthalmic manifestations and no systemic symptoms. And the most important thing is multidisciplinary approach in such cases to prevent the patients from mortality and morbidity due to end organ damage. Thank you.
Thank you very much. In fact, it's a very good case because we must pay attention to systemic things along with just looking at the eye as a single organ. So thank you very much for bringing that out. And the next and the last presenter is Dr. Shupra Burman, Rising IOP, Who's to Blame. So could we just have you fast, Peter?
Good afternoon, everyone. My today's topic of presentation is Rising IOP, Who's to Blame. A 31-year-old female student from Kolkata came with the complaint of heaviness in her both eyes for 7 days, which is associated with sudden onset of, sudden in onset and associated with mild pain. There was no history of watering, burning sensation. Initially, she has been diagnosed elsewhere as physiological large cup, and she was on regular follow-up. There was no history of ocular trauma, no significant medical or surgical history, no history of similar illness in the family, and no family history of glaucoma. General and systemic examination reveals no abnormality. Her external examination was within normal. The best corrected visual acuity in the right eye with minus 0.50 sphere was 6.6 and near vision was N6. And in same also in the left eye with minus 0.50 sphere, it was 6.6 and near vision was N6. The ocular examination, the anterior segment was normal. With the intraocular pressure with applanation tonometer, it was 24 millimeter of mercury in the right eye and 26 millimeter of mercury in the left eye. And in the gonioscopy, we could say there was a grade 3 according to Schaeffer's grading with the peripheral anterior synechia superiorly in both the eyes. The fundus examination, as the picture shows that the VCT, vertical cup-disc ratio was 0.8 and pink in color, margins were clear, the neuroretinal rim were normal, deep cup foveal reflex was present in both the eyes. The vessels were arising from the optic disc and they were dichotomously branching. So from this history and the examination, we came to the provisional diagnosis that it might be a case of ocular hypertension. We have done more investigations where the pachymetry showed that in the right and left eye both it is a 480 micrometer. Then the perimetry was within normal. And OCT RNFL revealed that in the left eye there was superior temporal and inferior rim thinning. Then we have done the ultrasound biomicroscopy which showed that there was a multiple small iridociliary cyst in both the eyes. So the diagnosis may be ocular hypertension secondary to intermittent angle closure due to iridociliary cyst. They managed the case with the topical medical therapy. Eye drop dorzolamide was used and she was kept on regular follow-up. After 3 months of follow-up, the intraocular pressure was 14 millimeter of mercury in both the eyes and the visual field and OCT RNFL remained stable. So iris cysts are broadly categorized into the primary and secondary cysts. They may be found at the following zones: the pupillary margin, between the iris root and the ciliary body, and most commonly at the iridociliary sulcus. Ultrasound biomicroscopy allows a better visualization and evaluation of the size, structure, location as well as the extent of the involvement of the cyst. Iris cyst may have a vast range of clinical presentation, ranging from totally asymptomatic, needing only observation, to full-blown glaucoma requiring major glaucoma surgery. So to conclude, considering the wide variety of clinical manifestation and that the management may differ depending upon the diagnosis, it is highly important for clinicians to carry out a careful examination, especially in patients with narrow angle. Even in BGOPD, outdoor proper history and thorough examination of the patient should be done. Otherwise, we could miss the diagnosis. These are my references. Thank you.
Cysts were there in both the eyes?
Yes, sir.
Because I believe you showed only in the left eye.
It won't come back. I mean, like,
yeah.
You
felt
in
it was in
UVM,
both
the
the eyes?
cysts were in both the eyes.
Okay.
Both are smaller, small in size.
So was there a difference in presentation in either of the eyes, because the glaucomatous defect was more in one of the eyes? So
Yes, ma'am. There was a difference in the left eye. The pressure was a bit higher, and in the left eye, in the OCT RNFL, we have seen that the field were.
yes, there is. But what about the cysts?
Cysts were same size only, but the presentation were more in the left eye.
Because the OCTA RNFL and the pressure difference was not much. How much was the pressure in both eyes?
Right eye, what was 24 millimeter of mercury. In the left eye, it is the 26 millimeter of mercury. The patient was having more complaint in the
So you believe the intermittent angle closure which was occurring was the reason. But right eye, perimetry, OCT, everything was normal, right? Okay.
Thank you very much. It's a known fact that cysts can cause, iridocerebral cysts can cause it, and the numbers and the dimensions also matter. But thank you for a very good presentation. And we have the honor today, thank you ma'am. We have the honor today of having Dr. Benjamin coming to speak to us, and I would request the house that none of the people, audience, please leave. We must hear what he has to say. He's come from another country, and we honor that, and we have the privilege of having him. And so first, we would like to show our appreciation in the customary applause.
So, till the time we are setting up the slides, so Dr. Benjamin Zhu, MD PhD, so he has received his BSc from the Yale University and followed by MD and PhD. He then completed his ophthalmology residency from the University of Southern California and glaucoma fellowship from the University of California, San Diego with Professor Venreb. And currently he's an associate professor of ophthalmology, chief of glaucoma services, and director of the data science AI at the University of Southern California. And he has a NIH-funded research focusing on developing novel diagnostic tools. He also uses epidemiological and electronic healthcare data to study the impact of glaucoma. And he also has published more than 85 peer-reviewed papers and received over a dozen of research awards. Over to you, Dr. Zhu.
Great. Thank you very much, Dr. Angmo, for a kind introduction. Wonderful to see all of you today. It's lovely to visit your beautiful country. I'd also like to thank Professor Dada for inviting me to speak today. I just want to mention before I start that I do receive research support from Heidelberg Engineering, and I'll be talking about their anterior segment OCT device. So before I begin, a show of hands, how many of you use anterior segment OCT in your practice or have used it before? Okay, wonderful. Yes, this technology has rapidly evolved over the last several decades and has become quite commonplace in clinical use. The earlier time domain devices were slower, lower resolution, but now we have spectral domain and swept source devices that provide us with beautiful high resolution images of the anterior segment, such as this one. So this is a representative AIOS2025 image, and we can clearly see here the cornea, the iris, and the lens. One structure that's not easily visible is the trabecular meshwork. And so in order to identify angle closure, we have to identify the scleral spur, which is the structure that sits directly posterior to the TM in order to identify angle closure. And here's a representative image of an eye with an open angle. Here the scleral spur is shown with the yellow arrow, and we can see that there is no contact between the iris and the intercorneal curvature anterior to this. This is an image of angle closure. What we can see is that there's contact between the TM and the iris anterior to the scleral spur, and this is iridotrabecular contact, also known as ITC. AIOS2025 images can also be assessed quantitatively. We obtain measurements of the size, shape, and configuration of the anterior segment and its anatomical structures, but first we have to segment the cornea, the iris, and the lens, and mark the scleral spurs. After doing so, can we obtain these measurements that inform us about the anterior segment. So I have two cases for you today, drawn from my own clinic, that illustrate how I use AIOS2025 in my own clinic. This first patient is a 62-year-old Asian female who is coming with the question, do I need laser for my eyes? She's a dentist, she's seeking a second opinion about LPI, and she is asymptomatic. She has no relevant history. On baseline exam in 2021, she has 20/20 vision in both eyes with a pressure of 18 in the right, 19 in the left. She's a mild myope with an average CCT of around 590. On slit lamp exam, she's narrow by Van Herrick, has a trace NSC in both eyes. On gonioscopy, we cannot visualize pigmented trabecular meshwork in 3 of the 4 quadrants, but they do open on indentation to scleral spur in both eyes. And on undilated exam, she has a cup to disc ratio of 0.5 in both eyes. She has a reliable and full field in both eyes, and on OCT, there are no focal areas of thinning that might be suggestive of glaucoma in either eye. So at this point, I'd like to summarize the Zhongshan Angle Closure Prevention Trial, or the ZAP trial, which provided us with evidence for the management of this patient. This was a landmark randomized control trial that was published in The Lancet in 2019. And the purpose of this study was to assess the benefit of LPI for the prevention of angle closure. The ZAP trial recruited 889 bilateral primary angle closure suspects, all of whom were between ages 50 to 70 and mainland Chinese, and these participants were randomized to LPI in one eye and monitoring of the other eye. These participants were followed for 6 years, and the endpoint was progression to primary angle closure, which was defined as formation of PAS more than 1 clock hour, elevated IOP over 24 millimeters of mercury, or an acute primary angle closure attack. The ZAP trial yielded 2 important findings. The first is that LPI does work in reducing the risk of progression by around 50%. However, the other important finding is that the risk of progression is very low even in untreated PACS eyes, which is the state of this patient's eyes. So the question here then is, this patient has PACS in both eyes. How do we further risk stratify this patient to decide whether or not she needs treatment? So at this point, we got an anterior segment OCT of both eyes, and I've marked here the scleral spurs in both eyes. And what you can see here is that there is no iridotrabecular contact in either eye. You can see zoomed in here is that there is still a slit between the trabecular meshwork and the iris that allows for aqueous to flow out of the eye. Also, we got a measurement of angle width in the form of angle opening distance, which is the distance between the trabecular meshwork and the iris. And this measurement was 0.13 millimeters in the right eye and 0.12 millimeters in the left eye. I know right now that doesn't mean anything to you guys, but by the end of this lecture, hopefully it will. So I'd like to, at this point, just summarize a study that my lab performed in conjunction with the authors of the ZAP trial that we published in 2022. The purpose of this study was to better understand the clinical significance of ASOCT measurements in PACS eyes using data from the ZAP trial. Here we took data from 643 untreated PACS eyes that had received gonioscopy and anterior segment OCT at baseline, and our outcome measure was progression from PACS to PAC. This table shows our primary finding. Here in this multivariable model, our measurement of angle width is angle opening distance, or AOD. You can see that AOD, adjusted for age, iris curvature, and anterior chamber depth, is significantly associated with progression. Specifically, for every 10 microns smaller in AOD, the risk of progression increases by around 10%. When we replaced AOD with gonioscopy score, which is a sum of the gonioscopy grades across the 4 quadrants, we found that gonioscopy score was not associated with progression. What this tells us is that gonioscopy fails to provide us with information about progression risk, whereas ASOCT measurements can help us perhaps risk stratify these eyes. So how do we apply this in our evidence-based care? Well, in the ZAP trial, the mean AOD measurement was 0.09. So around half of the participants had an AOD greater than this. And what we know is that our patient has an AOD that exceeds this mean, which means that in terms of angle width, they're in the wider half of the cohort. So this would imply that the patient is at relatively low risk for PACS eyes. We also know, based on other work, that the more ITC that we see in ASOCT images, the higher the risk for PAC and PACG, and as we saw, this patient has no ITC on their ASOCT images. So we diagnosed this patient as a low-risk primary angle closure suspect. We had a discussion regarding LPI, but the patient ultimately elected to monitor annually. She was given acute angle closure precautions. So we continue to follow this patient. Most recently, I saw her in May of last year. Her pressure remained stable at around 19, and the rest of her exam also remained very stable. Her visual field has been full, and her OCT RNFL thickness has been unchanged. So our plan is to continue annual monitoring, and we're monitoring her for elevated intraocular pressure or the development of a visually significant cataract, at which point we will perform lens extraction. So the second case is a 41-year-old Caucasian male who is coming asking, do I have narrow angles? He works as an investment banker referred by an optometrist for an angle evaluation and is otherwise asymptomatic. He has a family history of narrow angles, and his mother, who received an LPI and had an unpleasant experience due to dysphotopsias. So we see here that he's 20/20 in both eyes with a pressure of 17. He's a mild hyperope with an average CCT of around 580. On exam, the patient is also narrow by Van Herrick. Here we can't visualize any angle structures except on indentation, where we can see pigmented trabecular meshwork in the inferior quadrant. There is no cupping on undilated fundus exam. The visual fields are reliable and full in both eyes. The OCTs are thick and reassuring in both eyes as well. So these are the ASOCT images for this patient. We can see the scleral spur is marked in each image, and there is iridotrabecular contact in all of these images, implying that the angle is very narrow in all sectors. And also, we measured the AOD, which was less than 0.05 millimeters in all sectors. We got a UBM in this case just to see why this young man had such bad angle narrowing. He has elongated anteriorly rotated ciliary processes, which suggests he's on the plateau spectrum, and we also found that he has ciliary body cysts as well. So at this point, we were considering what we should do, whether we should monitor LPI or do clear lens extraction, and you can do this exercise in your own head. But here we decided that we needed to practice evidence-based care. So as you know, in the ZAP trial, the mean AOD was 0.09. This patient is narrow in all sectors below this mean value, and also has ITC in all sectors compared to our last patient who had no ITC. So we diagnosed this patient as high-risk PACS. We recommended LPI given these ASOCT findings. We counseled him about the plateau iris and the ciliary body cysts, and ultimately he was very cautious about LPI due to the negative experience that his mother had had, and so he deferred the LPI. And so I gave him acute angle closure precautions, and we decided to follow every 9 to 12 months. So fast forward a couple years, now it is September of 2023, and he comes in for the first time with elevated intraocular pressure of 24 in both eyes. The rest of his exam is unchanged. We can see here that his OCT RNFL thickness remains full and unchanged despite the change in IOP. So at this point, we had a new ASOCT device. Here you can see beautiful images of the entire anterior segment, and our AOD 500 is 0.03. So now you guys are all becoming experts about AOD. This is a very narrow angle. In the right eye and also in the left eye, it's 0.05. So here, the recommendation by the World Glaucoma Association, American Academy of Ophthalmology, and the Asian Pacific Glaucoma Society is that angle widening treatment is indicated as this patient now has progressed to PAC. There is substantial evidence suggesting that patients who receive LPI experience significant angle widening that can be measured using ASOCT. And we also know, based on landmark studies such as the EAGLE trial, that LPI can effectively lower intraocular pressure in PAC eyes. So here, this patient was much more amenable to LPI now that he had elevated IOP, and so we proceeded to perform the LPI in both eyes. Here we can see the angle widening benefit of the LPI. His AOD has gone from 0.03 to 0.12 in the right eye. And he didn't experience quite as much angle widening in the left eye, where he went from 0.05 to 0.08. Still, his IOP did come down after the LPIs to 18 and 17 and has remained stable. He was counseled about the possible need for clear lens extraction in the future if his pressure is to go up again. And we were following him more closely due to the residual angle narrowing despite the LPI. So here I'd like to finish with just one more point, which is that we have certain clinical gaps or barriers that prevent us from using ASOCT efficiently in our clinics. And one is that you need a certain amount of time and expertise before you can obtain these useful ASOCT measurements. So fortunately, we have access to artificial intelligence, or AI, which is a transformative technology that promises to change our daily lives. We use convenient tools such as ChatGPT to answer all of our questions, and large language models like DeepSeek have had profound economic impact across the world as well. So in 2020, my lab published this paper in which we automated the scleral spur detection in ASOCT images, which is the key step to getting these measurements. And more recently, we worked with Heidelberg Engineering to develop a similar algorithm for the FDA-approved Anterion ASOCT system. And so here we developed an AI algorithm using around 4,000 images that had scleral spur locations marked by an expert. And before we adopt this kind of tool in our clinical practice, we need to thoroughly validate it. And that's what we did. We collected 1,300 images at USC, and we marked 2,600 scleral spur locations. And this scatter plot shows the agreement between two humans. This error is calculated as the reference minus the predicted scleral spur coordinates, and we can see the median error is around 60 microns. Here's the agreement between the human and the machine. You can see the scatter plot looks very similar, and the median error is also similar at around 56 microns. This table shows intra-class correlation coefficients, which measures the amount of correlation between two sets of measurements. In the left-hand column, it's the agreement between an expert grader and a glaucoma specialist. And we can see that these ICC values are all very close to 1, which shows that there's a high degree of correlation between two human graders. This high degree of correlation is matched by the human and the machine, which also shows very high ICC values for all parameters. What this means is with a simple click of the button, we now have access to expert level measurements, making this technology more accessible. So in summary, ASOCT imaging can be very useful for the care of our angle closure patients. Recent research helps advance evidence-based care, and AI makes this technology and ASOCT measurements more accessible for busy clinicians. However, we still need further advances and research before we can widely adopt this technology for the care of our angle closure patients. So thank you very much. It was a pleasure. I'd like to acknowledge the hard work of all my lab mates, and thank you for your attention.
That's a very nice presentation of objective assessment and to see the progression of PACS in the clinical course. So you think the most important parameter which I could understand from your studies, AOD 500. If depending on AOD 500, you plan the further the treatment strategies, whether to do LPI and or to do clear lens extraction. Is that so?
Yeah, that's a great question. So I mentioned AOD 500 in this study because, or in this context, because in the study that I described, that was the most predictive of progression from PACS to PAC. We find, though, that depending on the outcome measure, whether you're looking at progression or IOP, sometimes the exact measure of angle width, the parameter describing angle width, can vary. So sometimes it can be the area in the angle, sometimes it can be angle opening distance. So this is something that we're still working on in the field to figure out which one parameter should we be using. But AOD is certainly very easy to measure and understand.
Doctor, how about the exact, determining the scleral spur, because I think that's the main point. So how are you sure that you've been able to go on to the scleral spur?
Yeah. So in the scatter plots that I showed, one of the graders was me, and then I have a research technician who's graded over 20,000 images, bless his soul. And so we really wanted people who were experts in identifying the scleral spur to be the reference, to be the comparison. And I think given that the agreement between the machine and the human matches this and is actually a little bit better, I think this gives us a high level of confidence that the algorithm is working very well. And we need to make sure that it works well because we're going to be using it in clinical care.
Thank you.
Okay, thank you everyone. And in the interest of time, I would just call all the speakers and the judges and the moderators for the photograph session. Dr. Ben.
Thank you, Dr. Benjamin, to be a part of this PG Capsule program. And next session is on ocular trauma and miscellaneous. And I would like to request Purendra Bhasin sir, Dr. Pradeep, Dr. Neetu, please come to the dais, and Dr. Mukesh sir.
All the presenters, please come.